Facing corneal opacity and cataract surgery constitutes one of the toughest challenges in our quest for vision restoration. This video highlights an unusual case of phaco emulsification with implantation of a toric IOL in a patient with a stormy cornea. The patient is a 65-year-old white male who was originally referred for an evaluation of corneal transplantation of his left eye, which endured a corneal perforation at age 6. The patient states that he was evaluated by the local ophthalmologist who only prescribed drops. No surgery was performed at the time of the injury. The vision of this eye has remained stable over the years, until recently when he noticed a decrease in visual acuity. Past medical history was unremarkable. Upon examination, CDVA was 20/200 with the refraction on the screen. Slit lamp examination revealed a wide central corneal scar, approximately 4 by 3 mm, a temporal peaked pupil due to the anterior synechia, and an anterior polar cataract right underneath the scar, partially encroaching on the visual axis. Potential acuity measurement of 20/40 could be obtained by means of a lambda retinometer. Therapeutic options were discussed, and the patient informed that the best course of action would initially involve the removal of the cataract only. After a thorough explanation on the potential need of a corneal transplantation, he was reluctant to have any surgery on this eye, since he had the cosmetic blemish for his whole life. A year and a half later, he returned to the office, asking to have only the cataract removed. Further corneal evaluation was carried on by means of a Panacam examination, which displayed a 2 diopter with the rule astigmatism at the 97 meridian as seen here. There was an obvious corneal thickening at the perforation site. The anterior synechia was readily visible on this anterior chamber view. Since the patient would not seek further corneal surgery, a toric IOL was suggested, and the calculator recommended a Acrisof SNAT3 implanted at the 97-degree meridian, with a 2.2 mm incision at the 105 meridian. Surgical planning involved the release of the anterior synechia by blunt dissection with the OVD cannula for pupil enlargement and consequently better cataract visualization. Capsulorhexis was initiated at 9 o'clock in an attempt to encompass the anterior capsular perforation, which was achieved. The nuclear, epinuclear, and cortical material were readily aspirated. The toric IOL implantation and rotation to the desired meridian underwent uneventfully. In an attempt to enlarge the pupil nasally, 3 sphincterectomies were performed with microscissors. Slit lamp pictures and HD video displayed here on the 7th post-operative day show a deep anterior chamber and an otherwise regular slightly nasally decentered pupil. The patient was very pleased with the result and even required cataract surgery on his right eye. CDVA was 20/40 with the refraction on the screen. Surgeons face a big challenge when treating patients with cataract and corneal comorbidities. Hopefully, current techniques for optimizing visual outcomes in these patients are readily available. If a patient's scar requires a corneal transplant, Treating the cornea first, the cataract first, or doing a combined triple procedure each have advantages and disadvantages. Usually, surgeons tend to operate on the factor that most affects vision first, and if they have equal contribution, a combined triple procedure becomes the most appropriate choice. Identifying the scar's impact on the shape of the cornea as well as its degree of opacification are keys for deciding the best course of action. The advent of corneal tomography has helped us tremendously in determining the best surgical strategy. Superficial keratectomy and excimer laser PTK are viable options for cleaning the cornea prior to cataract surgery. Afterwards, one can easily correct for changes in the corneal curvature with the IOL power calculation. Surgical technique is of paramount importance. Incision location could be utilized to lessen the astigmatism, depending on its severity as well as the use of toric IOL. The application of the soft shell technique to protect the already compromised corneal endothelium, the use of external light source, enlarging the pupil or using capsular staining to get a better view are some of the strategies often used in these challenging cases. The literature, although scarce, also demonstrates good outcomes operating only the cataract in eyes with coexisting corneal opacities. We should also bear in mind that despite the recent advances in corneal transplantation, performing only the cataract surgery will result in surprisingly good outcomes in these challenging cases, depending on the severity of the corneal opacification. In the case at hand, although there is a significant central corneal scar in an amblyopic eye, performing the cataract surgery along with the implantation of a toric IOL resulted in a fairly good outcome. When facing stormy situations, resorting to all the current available techniques and diagnostic tools will safely take you to smooth seas. Thank you very much for your kind attention.